So we'll go ahead and begin. My name is Jason Blake. I am the agency manager for Nevada Health Authority, and my responsibility is over the Rural Health Transformation Program here in the state. And it's my pleasure to welcome you all to part two of our Rural Health Transformation Workshop. And today and yesterday, we are dealing specifically with the Rural Health Innovation and Technology Initiative. These two workshops
Innovation and
are
Technology.
I'm getting a little bit of feedback. Does everyone else hear feedback? Okay. Our workshops are being recorded, and when ready within the next couple of days, will be posted on our website for further references. And so with that, we'll move in to our agenda with public comment. No action may be taken upon a matter raised under public comment unless the public comment period, unless the matter itself has been specifically included on an agenda or as an action item. Comments will be limited to 3 minutes per person. Persons making comment will be asked to begin by stating their name for the record and spell their last name and provide rhtp@nvha.nv.gov with written comments. Comments must be provided up to and including the day of meeting by 5 p.m. for inclusion on the record. Is there any public comment at this time? Hearing none, we will move into item 2 on our agenda. And I'd like to recognize and welcome 2 representatives from Health Management Associates, also known as HMA. They've been our partners in this initiative. And specifically, I'll turn it over to Lee and Arun for the presentation.
Thank you. I'm just going to kick off by sharing screen and we'll begin the presentation. And there we go. Are we all seeing my screen? Just to double check.
Yes.
Excellent. Thank you, Erin. So good morning, everyone, and welcome to today's workshop, Rural Health Information Technology, Health IT Tools and Functionalities. My name is Lee Rapash, and I'm joined today by my colleague, Arun Natarajan. We're both with Health Management Associates, as Jason let you know, and today's session is being presented in partnership with the Nevada Health Authority. Today is really about application. The 3 RHIT tracks we are going to walk through represent the major investment areas under the upcoming RHIT procurement. We'll walk through the 3 tracks and highlight the kinds of technologies and use cases that may fit under each one, especially what makes sense for rural and frontier providers. To set a bit of context, yesterday's session focused on the why and the foundation. And if you weren't able to join us yesterday, no worries. Today's session is designed to stand on its own and will reinforce just enough of what that background from yesterday to keep everyone oriented as we go. Yesterday, we spent time grounding RHIT in the Centers for Medicare and Medicaid Services, or CMS, health technology ecosystem, and the direction CMS is setting for modern health IT, interoperable, standards-based, secure, and trusted data exchange. We reviewed the CMS interoperability framework, CMS aligned networks, and the core capabilities CMS expects for participation in a trusted digital health environment, including identity, query and response, auditability, and privacy and security. That presentation should be available through NVHA in the next couple of days. Today builds directly on that foundation. If yesterday was about understanding the landscape and expectations, today is about translating that into practice, what the direction means on the ground for rural and frontier providers through RHIT. We'll walk through each of the 3 RHIT tracks, talk about how they differ, and show illustrative examples of technologies and use cases that may fit within each one. As we go through today's discussion, we encourage you to keep the CMS health technology ecosystem in mind. RHIT-funded technology should align with that broader direction. which basically means prioritizing interoperability, security, and long-term sustainability over one-off or isolated solutions. And finally, just to set expectations, our goal today is to help you think clearly about fit. We're not here to sell a particular solution or push anyone toward an application or vendor. This session is about supporting informed, realistic planning and helping you understand what may and may not align with RHIT priorities. So here's how we'll spend our time today. We'll start with a quick look at today's session goals and then spend most of our time walking through the 3 RHIT tracks. Each track reflects a different way of thinking about health IT investment. So we'll talk through how they differ and what that means in practice. We'll wrap up with time for questions and discussion. And please feel free to jot down questions as we go. This is meant to be interactive, and we want to make sure today is useful and relevant to what you're thinking about in your own organizations. And just a quick note on how we'll handle questions and interaction. We will not be moderating the chat during the presentation, so please feel free to use the chat to introduce yourselves and connect with one another. We encourage that. We'll pause for a short Q&A at the end of each RHIT track, and we'll also leave time at the end of the session for additional questions and discussion. These are the outcomes we're aiming for today. First, we want you to understand how the 3 RHIT focus areas or tracks differ, not just in name, but in intent. Second, we'll talk about the types of technologies and use cases or examples of projects that tend to fit within each track. Third, we'll highlight examples that are particularly relevant for rural and frontier providers, recognizing the constraints many of you face around workforce, capital, and IT capacity. And finally, we want to create space to ask questions and pressure test whether particular ideas align with RHIT priorities. Again, please feel free to use the chat to connect with one another during the presentation. So this is just a basic overview of RHIT funding. RHIT funding is organized around 3 health IT tracks or investment areas. These tracks are not simply technology categories. They reflect different domains of the digital health stack, ranging from foundational infrastructure to care delivery tools to consumer-facing solutions. Keep in mind, they are not meant to represent levels of sophistication or readiness. One important theme throughout all 3 tracks is that RHIT favors investments that are shared, scalable, and sustainable, particularly in rural and frontier contexts where individual organizations often cannot and should not go it alone. As we walk through each track, think about where your current challenges lie, whether you're building the foundation, looking to extend care delivery, or exploring supportive tools for patients. And with that, I'll pass the baton to Arun, who's going to lead us into track 1.
Thank you so much, Lee. Always great to see you. One quick housekeeping rule. We're going to be going through each of these 3 tracks with a sense of what's first, what is the track, talking about technologies and vendor solutions, technologies in a track, agnostic of vendor solutions, but where there are vendor solutions in the ecosystem. So we'll be talking about the technologies, not a specific vendor. And then the third is exemplar or sample use cases that sort of thread the needle on what the track was trying to focus on and what are the technologies that are currently available. Please use the chat. The chat is not being moderated by us. If you're an applicant and you're exploring a specific use case for yourself, maybe you could share that in the chat. And other applicants who are exploring that same use case could then talk to you about it. As we talk about solutions that are existing in the, or challenges that are existing in the tech ecosystem, feel free to introduce yourself to your colleagues here and to everyone else in the meeting. The chat is not being moderated, but it is an opportunity for you to connect with each other. Okay, with that, let's start off with track 1. So track 1 is really the foundation layer. As we think about the foundation, track 1 focuses on shared core health IT capabilities that rural and frontier providers rely on every day to securely access, exchange, and use health information. In simple terms, This is the digital plumbing that has to work well before more advanced digital care models can succeed. This track is especially relevant for providers with limited internal IT capacity, aging systems, or fragmented infrastructure. It is also relevant for organizations that are trying to reduce duplicative investments by participating in shared or scalable infrastructure rather than building everything independently. In many rural settings, that shared approach can be more realistic, more sustainable, and more cost-effective over time. The kinds of problems this track addresses are foundational problems: fragmented systems, data silos, the high cost of maintaining standalone infrastructure, and gaps in security or interoperability. These are often the hidden barriers that make it difficult to improve care coordination, adopt digital goals, or participate more fully in a broader data sharing environment. So when you think about track one, think about prerequisites. This is the track for projects where secure access, interoperability, shared infrastructure, or cybersecurity has to come first. And as we move into the next slide, listen for the kinds of technology categories that build that foundation and enable future digital care efforts. Okay, thank you so much, Lee. On this slide, the easiest way to think about track one is that there are already vendor solutions in the market for each of these problem areas. So the conversation is not whether solutions exist. They do. The more important question is which types of solutions make sense for you, for rural Nevada, and whether those solutions are scalable, interoperable, secure, and sustainable over time for you. Starting with the foundational infrastructure and shared services, there are vendors that offer shared cloud hosting environments, managed EHR infrastructure, regional platforms, identity and access services, and other managed IT capabilities. For smaller rural providers, the value of these kinds of solutions is that they can reduce the burden of standing up and maintaining everything locally. Instead of every organization building its own environment, vendor-supported shared infrastructure can spread costs, improve reliability, and create more consistent technical foundations across sites. In interoperability and data exchange, there are many vendor solutions focused on APIs, interface engines, integration layers, health information exchange connectivity, patient matching, and data routing services. Some vendors specialize in FHIR enablement, some in cross-platform integration, and others in connecting providers to health information exchange services or broader data sharing networks. The important point here is the market has mature tools for moving data across systems, but RHIT aligned projects should prioritize standard-based solutions that support long-term interoperability rather than custom one-off interfaces that are expensive to maintain. For cybersecurity and risk management, there's also a broad vendor landscape. Organizations can produce and procure outside support for security risk assessments, penetration testing, managed detection and response, endpoint protection, multi-factor authentication, access monitoring, vulnerability management, security awareness training, and preparation using recognized frameworks or certifications. In other words, even small providers do not need to build an entire cybersecurity program by themselves and from scratch. There are vendor offerings that can help fill gaps, especially where internal IT and security staffing is limited. In care coordination and analytics, vendor solutions exist for shared referral management, closed loop referrals, population health analytics, quality reporting, dashboarding, event notification, and care management workflows. Some tools are designed to help providers identify care gaps, track chronic disease outcomes, or meet reporting requirements for value-based models. Others are designed to improve transitions of care by making referrals and notifications more visible across organizations. So this is another category where the market has a fairly mature product offering. The question for you is how to deploy them in ways that truly reduce burden and improve coordination across your system. Finally, governance, sustainability, and technical assistance. There are vendors and external partners that support data governance designs, trust agreements, implementation planning, workflow redesign, training changes, change management, post-implementation support. This category is easy to overlook because it's oftentimes less tangible than software, but it is often the difference between a successful project and one that never gets adopted. Many organizations need not only the technology, but also a partner that can help stand up the governance and operational model around it. So the main message for this slide is vendor solutions exist in all of these domains. RHIT is not asking organizations to invent new categories of technology. Instead, it's asking organizations to strategically think about which existing solution types best solve their rural challenges, align with CMS expectations, and can be implemented in a way that is shared, secure, and sustainable. I'd like to now move this over to the next slide.
Thank you. And in this slide, we're going to talk about some sample use cases or illustrative examples. And pardon me, it takes a second to switch in between slides and turn on my mic on and off. So the next two slides are going to give a few concrete examples of what these shared services or collaborative models can look like in practice. These are just examples. It is not a complete list. The key idea across all of these examples is that shared infrastructure, shared responsibility, and long-term sustainability, especially for smaller and rural providers. So in one example, several small or rural providers decide to use the same secure cloud-based system. Instead of each provider managing their own technology separately, they can share access to electronic health records, exchange data with each other, and run basic reporting or analytics together. This helps lower costs and reduce the technical burden on any one organization. Another example is a critical access hospital that receives subsidized access to certified health information exchange. This lets the hospital receive care alerts, share discharge information, and coordinate follow-up care with other providers, even if the hospital wouldn't otherwise be able to afford that type of infrastructure on its own. Here are a couple more practical examples of what shared services can look like. Other examples may include where a network uses event notifications like admit, discharge, transfer, or ADT, or ED visit notifications, so primary care teams and care coordinators are alerted promptly and can follow up after hospital events. Projects could support shared imaging, exchange, or cloud PACS, or picture archiving and communication systems, used to store, view, and share medical images. Several rural sites could use the same imaging platform, so scans can be sent to radiology partners and pulled up at different locations when needed. This means each site doesn't have to build and maintain its own separate imaging system, which saves money and reduces complexity. And another example might be a regional analytics utility. A group of providers could work together to build a shared reporting layer that supports quality reporting, value-based payment requirements, and population health dashboards. Instead of every provider recreating the same reports, the work is shared and the overall reporting burden is lowered. The examples on the screen, as well as the examples given, are meant to show the range of possibilities: shared infrastructure, shared tools, and shared governance, rather than prescribing a single solution. And with that, let's pause for any questions or if you want to share any ideas you might have.
Hi, Lee.
And if
I think let me also ask our attendees today, use this as an opportunity to use the chat. Again, we're not moderating or monitoring the chat at this point, but you can use this as an opportunity to share who you are and what ideas you may be exploring so other people on the call can reach you or can hear about that.
So I don't see any questions, and you're welcome to ask them at the end. So with that, we're going to move on to the next track. Again, just give me a chance. There we go.
Thank you so much, Lee. Now we're moving from the foundational layer to the care delivery layer. So track 2 focuses on provider-facing digital health and remote care solutions that change how care is delivered and extend workforce capacity, especially in rural and frontier settings. If track 1 is the plumbing, track 2 is how providers actually use digital tools to deliver care differently. This track is aimed at organizations facing workforce shortages, access barriers, service delivery constraints. It's especially relevant for providers expanding virtual or hybrid care models, or for systems that want to embed digital tools directly into clinical workflows rather than treating them as standalone items or add-ons. The core problem this track addresses are limited access to specialty and behavioral health care, workforce capacity constraints, inefficient or fragmented care delivery workflows. In rural communities, these challenges actually overlap. A provider may not have enough staff, may not have enough local specialty coverage, and may also be working with processes that make care harder to coordinate than it should be. So when you think about track 2, think about workforce and workflow. This is the track for technologies that help providers reach more patients, work more efficiently, extend scarce expertise, and create more flexible care models. As we move into the next slide, listen for specific solution categories that support those goals and the kinds of care delivery use cases they enable. So let's move to the next slide. Thank you so much. On this slide, the key message is that there is already a strong vendor market for each of these track 2 areas. So just like track 1, the issue is usually not whether a solution exists, it's whether the solution is the right fit for you. The workforce challenge, the rural environment issues, or the long-term operating reality that you may be facing. So let's start with virtual and hybrid care delivery models. There are many vendor solutions that support telehealth visits, e-consults, asynchronous care, virtual scheduling, and shared virtual staffing. Some platforms are designed for direct video visits, and some are built around specialist consult workflows, while others support hybrid models where in-person and virtual care are coordinated together. For rural providers, the goal is usually not to buy the most feature-rich platform, but to identify solutions that are practical, workflow-friendly, and adaptable to bandwidth and staffing constraints. Remote and home-based care. Vendors offer a wide range of tools for remote patient monitoring, home-based clinical management, device connectivity, and decentralized diagnostics. That may include platforms that collect blood pressure, glucose, pulse oximetry, weight, or system information, and route those data back to a provider team. The important consideration here is not just that the device itself, but the surrounding workflow. Who reviews the information, how often, what triggers follow-up, and how that data fits into provider-directed care. For clinical workflow and decision support, there are also established vendor products that help with triage, digital intake, clinical routing, embedded decision support, and workflow optimization. Some tools help staff determine whether a patient should be scheduled virtually or even in person. Others support documentation workflows, task routing, or provider prompts inside the care process. In rural settings, these solutions can be especially valuable when they reduce friction on already stretched teams and help clinicians work at the top of their license. In care coordination and referral management, the vendor market includes referral platforms, transitions of care tools, closed loop referrals, discharge follow-ups, and care coordination dashboards. These solutions are often designed to make sure patients do not get lost during handoffs and that providers can track where a referral was completed. For rural systems, this can be critical because fragmentation and travel barriers can easily disrupt continuity of care. Finally, workforce extension and training. There are vendor-supported solutions here as well. For telepharmacy, telespecialty services, virtual care teams, provider training platforms. These can be especially important where it's difficult to recruit or retain specialty providers. Technologies in this category help local teams extend capacity without having to fully replicate every specialty service on site. The practical takeaway is that Track 2 is not about inventing a new technology category. It's about selecting from existing solution types in the market and applying them in a way that directly improve access, support workforce capacity, and fits the provider workflow. The strongest RHIT concepts in this area will show that the organization understands both care problems and implementation realities, not just the tools. Okay, next slide. Over to you, Lee.
Thank you. So here we're going to provide some examples of tools that are being used in practice, provider-facing digital health and remote care. This is not exhaustive or prescriptive, but it's just meant to spark ideas. So strong Track 2 projects typically show a clear connection between the digital tool and real access or workforce challenge, with measurable improvements in care delivery or efficiency. So taken together, these use cases show how Track 2 investments extend clinical capacity and access by embedding digital tools directly into care delivery, either through virtual services, remote monitoring, workflow tools, and mobile or distributed care models. Some key examples include a rural hospital may integrate telehealth specialty services, so telespecialty services like teleneurology or tele-ICU, so patients can access specialist expertise without leaving the community, while health systems could deploy telepharmacy services to expand access to pharmacists, improve medication safety, and support patients in areas with limited pharmacy coverage. Providers could also employ remote patient monitoring to keep track of chronic conditions at home, helping catch issues earlier and reducing avoidable hospital stays. In frontier areas, dental providers may use mobile dental vans equipped with integrated health IT to deliver preventative and basic services at schools and community centers where permanent clinics aren't feasible. Other examples may include embedding a telebehavioral health hub into rural primary care, using virtual behavioral health providers, warm handoffs, and shared scheduling, so mental health support is part of routine visits, not a separate referral patients struggle to follow through on. Another example looks like community paramedicine or mobile integrated health supported by digital workflows. In this model, a county EMS or community paramedicine team uses digital tools to support home visits, post-discharge follow-ups, and chronic disease check-ins. And what's important is that this isn't happening in a vacuum. The documentation flows back to the patient's primary care team, so those visits become an extension of the care plan rather than a parallel service. Another example looks like bringing care closer to patients through school or community-based telehealth access points. In this model, a provider partner sets up a telehealth-enabled room or scheduled telehealth days in places like schools or community centers. The goal is to reduce travel burden for patients while keeping care provider-directed and connected to the patient's usual care team, so it expands access without fragmenting care. As you are aware of, low bandwidth is also an issue in remote and rural communities. Sample solutions may also include low bandwidth hybrid telehealth operations, where a provider implements a hybrid-first telehealth workflow that can flex between video, audio only, and asynchronous modalities based on connectivity realities and patient digital literacy constraints. And with that, we'll pause for any questions or comments. And if there are none, I'll pass it back to you, Ron.
Thank you. Before we move into track 3, I wanted to pause a second on this resource slide for a moment because it highlights an important point that applies across all 3 tracks. We're sharing this as an example resource. It's not a requirement. In other words, this is not a mandated partner, not a required pathway, and not the only source of support an organization could use. The reason it's included is to illustrate a broader lesson about rural health IT implementation. In rural contexts, especially technical assistance, planning, support, and regional partnerships can be just as important as the technology itself. Many organizations do not struggle because there are no tools in the market, right? They struggle because implementation is hard. Questions come up around workflow redesign, staffing connectivity, training, sustainability, vendor selection, and how to integrate a new capability into the day-to-day operations without overloading a small team. This is where a resource like the Southwest Telehealth Resource Center can be valuable. It represents the kind of external support structures that can help providers think through readiness, feasibility, and implementation strategy. Sometimes what an organization needs most is not another platform, but help deciding whether the proposed model is realistic, what order to implement things, and how to align digital tools with local capacity and patient needs. This is especially true in rural settings where providers may have limited internal IT staff, fewer operational reserves, and less room for error if a technology project does not go as planned. In those environments, planning support and regional partnerships can reduce risk, accelerate learning, and help organizations avoid making investments that are difficult to maintain over time. So the key takeaway from this slide is that successful RHIT implementation is not just about choosing the right technology, it's also about having the right support around that technology, the right planning, the right technical assistance, and the right partnerships. And for many rural providers, those support elements are what make the difference between a project that sounds promising and a project that's actually sustainable. With that in mind, let's turn to track 3. So track 3 is the patient support layer. Track 3 focuses on limited customer-facing digital tools that support patient engagement, prevention, and self-management while still reinforcing the provider-based care. So unlike track 2, where the tool is primarily changing provider workflow, track 3 is about helping patients stay connected, informed, and supported outside of the visit. The track is intended for programs that support patient engagement between visits, particularly for rural or hard-to-reach populations, and for care models that relied on provider-directed oversight. But this is really important. It's important to stress that the track comes with tighter guardrails than the others. That is, funding is more limited. Tools supported here are meant to remain supplemental to provider-led care delivery. The main constraints are important. The tools must not provide clinical diagnosis or treatment decisions. They need appropriate privacy, security, and escalation safeguards. In other words, these can be useful tools for reminders, education, symptom tracking, communication, and navigation, but they are not meant to function as independent clinical decision makers. So when you think about track 3, think about support and guardrails. This is the track for technologies to help patients engage in care, especially in rural environments with connectivity or access barriers, but in a way that remains safe, non-diagnostic, and tied back to the provider relationship. As we go to the next slide, listen for the solution categories that fit within those boundaries. Thank you, Lee. On this slide, the main point is that that there are already vendor solutions in the market for each of these track 3 areas. So again, the question is usually not whether a technology exists, right? The real question is whether the tool is appropriate for the provider, for the applicant, whether it stays within the non-diagnostic guardrails, and whether it meaningfully supports provider-led care rather than operating independently. Starting with patient engagement and self-management tools, there are many existing vendor products that provide education, reminders, medication adherence support, wellness prompts, behavior change supports, and structured self-management programs. These tools are especially common in chronic disease management. The key issue for RHIT is that these solutions should remain supportive and non-diagnostic. They can reinforce a care plan, help patients stay engaged between visits, and improve follow-through, but they should not cross into making treatment decisions on their own. In remote monitoring and patient-reported data, there are vendors offering wearables, home monitoring devices, symptom trackers, connected apps, and platforms that transmit patient-generated data back to the care team. These tools can be valuable when they are embedded into provider workflows and tied to a care plan. But the technology alone is not enough. Organizations need to think about who receives the data, how often it is reviewed, what thresholds matter, and how escalation happens when something looks concerning. For communication and care team connectivity, there are many vendor solutions for secure messaging, patient portals, appointment reminders, provider-connected notifications, and structured patient updates. So this can sound basic, but in many rural settings, these tools can have a major impact because they reduce missed communication, they improve follow-up, and they keep patients connected to the care team even when travel or distance makes in-person contact harder. In caregiver and navigation support, vendor solutions exist for medication tracking, appointment coordination, transportation reminders, shared care checklists, and other settings where informal caregivers play a major role in helping patients manage appointments, transportation, and medications. A well-designed tool in this area can reduce friction and improve coordination without introducing clinical risk. And access, inclusion, and safety features. So there are vendors that specifically are designed for low bandwidth environments, multilingual access, accessibility supports with simplified interfaces, and escalation prompts. This is important because a consumer-facing tool only works if the target population can realistically use it. In rural settings, that often means choosing between solutions that work with limited connectivity, lower digital literacy, and a wider range of language or accessibility needs. So the takeaway for this slide is that track 3 is not about inventing a new patient app category. The market already offers many tools in those areas. The RHIT question is whether a given solution is safe, non-diagnostic, inclusive, tied back to provider oversight, and realistic for the populations the project is trying to serve. So when we look at the examples, which are coming up next, think of them as practical applications of these existing vendor solution types, selected and configured to support rural patients without drifting into standalone clinical decision-making. Over to you, Lee.
Thanks, I'm back. So now we're going to talk about some examples of consumer-facing digital tools in AI. Again, we remind you that these are illustrative, they're not exhaustive, and they're not prescriptive. So the emphasis in consumer-facing digital tools in AI is on supportive, non-diagnostic tools, and we keep stressing that. It's important to keep that in mind. So this includes education, reminders, monitoring, communication, and navigation tools. So track 3 needs to stay non-diagnostic, supportive, and tied back to provider-led care. The strongest proposals would show how these tools reinforce provider oversight, accommodate low connectivity environments, and serve hard to reach populations without introducing clinical risk. So some examples include individuals using non-diagnostic self-management apps to support chronic disease management, or caregivers coordinating medications and appointments through shared digital tools. For low bandwidth patients, so rural patients can use low bandwidth or SMS, smartphone, and based tools to stay engaged despite connectivity issues. Some other examples include some groups use caregiver coordination tools, things like shared checklists for medications, appointments, or rides, with reminders to reach out to the care team if something feels off. Other basic navigation tools exist so patients can quickly find clinic hours, mobile van schedules, transportation options, or how to contact their care team. This is nothing clinical again, it's just making access easier. Patients may also track symptoms or how they're feeling over time in a simple structured way, so providers can spot patterns without relying on memory. In maternal health, tools might include reminders for prenatal or postpartum visits, short educational content, and prompts to call the provider if warning signs show up. For chronic conditions, some programs send short micro-coaching messages, things like hydration reminders, diet tips, or medication prompts, based on the provider's care plan. And in low bandwidth settings, simple text messages can also go a long way. This includes appointment reminders, medication alerts, and two-way check-ins where patients can reply or get help rescheduling. So are there any questions or comments on track 3? Okay. And are there any questions or comments or use cases you want to propose for any of the tracks we've discussed, or anything you want to discuss during this call? Quiet audience today. Hey, Jason. And I see that some of you are using the chat to connect and reach out. Please continue to do so. Okay, if there's no questions or comments, Arun, we can talk about the next steps.
Sure. Thank you so much, Lee. Again, please use the chat to introduce yourselves. If you have a use case that you're exploring, put it in the chat. I'm sure other people would like to hear about your use case and maybe partner with you, or you could learn more about the use case through a mutual discussion. As we wrap up again, I want to close with some practical messages. The purpose of today's session was to help you understand 3 RHIT tracks, the kind of technologies that may fit within them, and the broader expectations around interoperability, security workflow, integration, and sustainability. The session is intended to support clearer thinking about fit, not to push anyone towards a particular solution or towards applications before they're ready. One important thing is that participating in this session doesn't commit you to applying for RHIT funding. The goal is to give providers, partners, stakeholders a clear framework for assessing whether a potential project idea is aligned with RHIT priorities and realistic in rural settings. For providers specifically, the next step is not necessarily to jump straight into a procurement or a platform selection. The better next step for some of you may be to assess your needs. Where are the biggest access gaps, workflow bottlenecks, interoperability challenges, security vulnerabilities, or patient engagement barriers? Which of those problems are foundational? Which are care delivery issues? And which might be best addressed through more limited patient-facing tools? It's also worth thinking about readiness, right? Do you have the staffing, partnerships, governance, and implementation support needed to make a project successful? As we discussed throughout this workshop, the strongest rural health IT efforts are usually the ones that are not just innovative, but operationally realistic, scalable, and sustainable over time. So the key takeaway here is that providers should use this information as a planning tool, reflect on where your organization's priority fit within the three tracks, identify what capabilities or supports would be needed, and continue those internal conversations before deciding whether RHIT is the right path for a specific project.
Okay.
Next
And
slide.
with that, I will try to go to the next slide. Here we provide some resources for you that will be available concerning RHIT, the CMS Rural Health Transformation Program, and Nevada's particular Rural Health Transformation Program and grant. We also provide some resources again with the Southwest Telehealth Resource Center and the Arizona Telemedicine Program, which is a university program that provides telemedicine services, distance learning, informatics, training, and telemedicine tech assessment capabilities in Arizona. They're very helpful to all other states too.
And I think we'll ask one last time if anybody would like to raise their hand to share a question, comment, please do so. We'll give that a few seconds. And then I think it's over to you, Jason. Is that correctly?
Yeah.
Okay.
All right. Arun and Lee, we greatly appreciate your work in this and your efforts to bring us all up to speed and to prepare us all for this RFP opportunity. Your expertise has been critical in this process, and we appreciate our partnership with you and our HMA friends. I see there is one question about when this will be released. We are expecting in the month of May for this to be released here soon. Please reach out looking at our website and getting signed up on the NVHA listserv so that you can receive those notifications when these funding opportunities go live. With that, if there are no further questions, we will open up for public comment here at the end of our workshop. And again, no action may be taken upon a matter raised under public comment period unless the matter itself has been specifically included on an agenda as an action item. Comments will be limited to 3 minutes per person. Persons making comment will be asked to begin by stating their name for the record. Are there any public comments for us to close our meeting? Hearing and seeing none, we will go ahead and adjourn, and thank you all for your participation, and we look forward to working with you on the RHT program.
Thank you, everybody.
Bye.